Osteopenia, you have heightened risk of fracture. Osteoporosis, even more elevated risk of fracture.
Thanks for watching Hot Flashes and Cool Topics podcast. Be sure to subscribe and ring that bell to catch all of our conversations. Now, on to the show.
Welcome back to Hot Flashes and Cool Topics. Today, we are going to have an important conversation with Laura Yecies. Welcome to the show.
Thank you. So glad to be here.
As we mentioned in the intro, you are the CEO and board member of Bone Health Technologies, and Bone Health Technologies has created Osteoboost. So, as someone who is postmenopausal and has been diagnosed with osteopenia, I saw this and I was like, okay, we need to get her on the show to talk about this option. So, Osteoboost is the first and only FDA approved non-pharmacological, that's a mouthful, non-pharmacological prescription treatment for low bone density. So, can we start with what does Bone Health Technologies do and how did Osteoboost come about?
Yeah, so we aim to provide a comprehensive solution to low bone density and prevent fractures. Our starting point is a FDA-cleared Class 2 medical device, which is a very novel device. We were granted a de novo clearance. And as you said, it's the first time there's ever been a non-drug treatment, prescription treatment approved by the FDA to treat bone density. And the other interesting thing is it's the first time there's ever been a treatment of any type specifically designed for osteopenia. And hopefully we can explore both of those topics in depth. The company was started or founded, the idea for the device came from a physical medicine and pain doctor, physiatrist, Dr. Shane Mangrum. And he's a specialist in back issues, and he was seeing patients with vertebral compression fractures. Those are the most common osteoporotic fracture. It sounds awful, right? Your vertebrae compress, and it is pretty awful. It can be very, very painful. And when women shrink, like we talk about little old ladies, they didn't always start out little. You know, there's some loss of height just, from gravity, but when your vertebrae collapse, that's a big problem. And then oftentimes it's the front of the vertebrae, which is what gives you that kyphosis hunchback position. So he was seeing, this issue. And there are good treatments for vertebral compression fractures. And so it really inspired him to try to find another solution. His patients didn't want to take drugs. Many of them who were taking medicine were still fracturing. And he collaborated with a medical device incubator that he's, a part of, although Dr. Mangrum's a practicing physician in this incubator, Theranova, did the early work on coming up with the spec for the device. So he, Dr. Mangrum saw this body of evidence on whole body vibration, and there's some good science to show that vibration improves bone density, but none of those devices were ever able to get an FDA clearance. If you look at the research on like Maradyne, low intensity vibration, a lot of the benefit is in the lower leg, right? Because you can imagine vibration sort of dissipates as it goes up the skeleton. So he had the idea of putting it in a belt. Actually, the idea was first to do a chair. And they did some testing with that, but it made people nauseous. So the next idea, which I think is really a winning idea, was to do a belt. And the belt gives you two key advantages. One is that the vibration is applied directly, locally to the vulnerable anatomy, the hips and lumbar spine. Hip fractures, those are the worst osteoporotic fractures. I mean, we've seen it with friends and family, I assume, right, where that hip fracture, people either don't survive the year or it's a sentinel event. They're in a nursing home, they lose independence. So we all want to avoid the dreaded hip fracture. So the vibrations apply to the hip and the lumbar spine, which obviously is to try to prevent vertebral compression fractures. So you have this local application of vibration. The second benefit is that it's a wearable. So you don't have to stand, in the corner on your vibration platform. You put it on and you go for a walk or you do your chores. And so Theranova was able to get some grants for clinical trial. a pivotal clinical trial was started at University of Nebraska Medical Center, and it was really for a small company. It was really interesting because we invested in a gold standard randomized controlled trial. So we really went all in to get the best evidence, something that could go to the FDA that we could really use as a foundation for our claims. And this study, had 126 postmenopausal women with osteopenia, and the results were essentially a home run because we had zero serious adverse effects, as you'd expect, and we reduced the loss of bone strength and bone density measured by CT scan, so highly objective endpoint, by 83 and 85%. So essentially, we're keeping our patients stable. And if you think about early intervention, you just don't want to lose bone. And some patients actually gain bone. We asked patients to use it 5 times a week or more. The average was 4. The patients who used it 4 and 5 times per week had a better result than those who used it 3. So, we definitely see that this has a very, very strong clinical efficacy. With that clinical result, we then applied to the FDA for a de novo pathway clearance, and that was granted in January of 24. The de novo process there, in the history of the FDA, there have only been 16 orthopedic de novos. So they're very, very hard to get. So I'm very proud that us as this small company, went down this challenging path. And the reason why we did it is because it's so needed, right? I mean, I have osteopenia, age 52, menopause, age 57, got my second DEXA, lost 13% of the bone in my lumbar spine. That was like a gut punch. And what my doctor said as well, keep exercising and taking your calcium. So basically keep doing what you're doing, which didn't work to prevent bone loss. And actually, so now I'm 61, I've done another DEXA using Osteoboost, N of 1. And I'm stable. I haven't lost any more bone, and I gained this tiny smidgen in the hip. So, if you think about comparing it to cardiovascular disease, we check people's cholesterol in their 30s, 40s, and we have safe interventions like statins, and we're trying to prevent your arteries from getting clogged up. So our goal is that we're checking bone density early. DEXA scans are safe and relatively inexpensive, and then intervening and preventing this bone loss. So that's what we're working on doing. We've had support from the government. The NIH has funded we've gotten 3 grants. Of course, we've had to raise money from investors. We haven't raised that much money in the grand scheme of medical device companies. And now we're getting ready to ship the product. So it's really exciting time.
So you were talking about the early intervention, and could you remind me the age that is usually recommended for a DEXA scan and really when you should get a DEXA scan?
Yeah, so this is a hot topic. Not a cool topic, a hot topic. So it has always been 65, get a DEXA scan, especially for women. Medicare funds, pays for it. It's recommended. And the rate of DEXA scans in that demographic is pretty high, I think in the 80% range. But rapid bone loss typically starts in menopause, which of course your listeners know is in the early 50s. And, women are typically getting into osteopenia in the 50s. Now, the U.S. Preventive Services Task Force just issued, I think they are considered draft guidelines. And in those guidelines, they're saying postmenopausal women with risk factors, which is probably a high percentage of postmenopausal women, should also be screened. Now, I was screened at 52. I mean, so that was long before this guideline. I think, a lot of proactive doctors are screening. Insurance typically covers it. If it doesn't, we're talking a test in the hundreds. It's kind of like dental x-rays. And there's less radiation actually in a DEXA scan than a dental x-ray. So I'm a big believer in early screening, right? Because you're losing bone in your 30s. So if you are below average in your 50s or even your 40s, it's all the more important to intervene, get going with exercise, nutrition, see if there's any reason for that early bone loss. Is there a parathyroid issue? Is there undiagnosed celiac? Um, you know, and let's try to keep, maintain that bone.
If we could take a step back, because I don't even know if every one of our listeners knows what osteopenia is. So, could we start with
Great
bone
question.
health and how
Mhm.
we start to lose it for women?
Sure. Um, So we build bone in our younger years. During puberty, there's tremendous bone building. So bones are very responsive to hormones, hence this bone building in puberty and typically in the 20s. So at some point on average, the 30s, our bone is peaked and we start to lose bone, right? Um, and we tend to lose it slowly in the 30s and 40s. And then a lot of the bone cells, like the osteoclast cells, are sensitive to loss of estrogen. So a couple years before menopause, it's actually not only post, and several years after, there's this escalation of bone loss, a heightened osteoclast activity. So osteoclasts are the cells that kind of eat away the old dead bone, and then osteoblasts build new bone. And osteoclast activity kind of goes into overdrive when you start to lose estrogen in perimenopause. So then you have typically this rapid bone loss. Now, someone who goes on a menopausal hormone therapy, you can slow or prevent this bone loss, but it's really a delay. So if you go off that hormone therapy 10 years later, you'll kind of go through that period. Um, you have a generation of women like my age, sort of especially throughout the 60s, who, when we went through menopause, we were told no HRT for you. So, I wasn't on HRT, I lost that bone, right? I talked about the 13%. So, what is osteopenia and osteoporosis? Um, the DEXA scan gives you a measure of bone density, right? Grams per centimeter squared. It's a two-dimensional image of three-dimensional bone, so it's not a perfect measure, but the benefit is it's, as I said, safe and relatively inexpensive. And then you are compared to a healthy 30-year-old, and they give you a T-score. And the T-score is measuring standard deviation. So if you have a -1, you are one standard deviation below normal. -2.5 or lower, 2.5 standard deviations below normal. 0 to -1 is still considered normal bone density. -1 to -2.5 is considered osteopenia. Below -2.5, osteoporosis. Um, Osteopenia, you have heightened risk of fracture. Osteoporosis, even more elevated risk of fracture. Now, the first question I typically get is, well, why are you measuring against a 30-year-old? Of course, a 60-year-old is going to have less bone, but it's simply a way to assess fracture risk. And there is good data that this bone density is associated with, as it goes down, higher fracture risk. By the way, age is associated with higher fracture risk. So if you have an 80-year-old with a -1.5 and a 60-year-old with a -1.5, the 80-year-old has a higher likelihood of fracture. There's also such a thing as Z-score, Z like letter Z, like zebra. There you're being compared to people your own age. So if you have any negative in your Z-score, you're kind of below the norm for your own age, right? So let's think about someone who's 40 and they have, a T-score of -1.5, or let's say -0.9. So they still have, quote, normal bone, but they could have a Z-score that's a negative. So you would expect someone in their 40s not to be that low. And then there's recommendations on treatment if you have, based on either your T-score, so -2.5 or below, oftentimes is indicated for medication. But there's now a tool called the FRAX, F-R-A-X, which takes multiple sources of data, including your bone density, although it doesn't require your bone density, and you indicate your age, family history, if you smoke, if you drink, if you use corticosteroids, and it gives you a fracture risk. So, generally speaking, doctors will treat more based on fracture risk than T-score. Um, Now, so this osteopenia thing is really an interesting question because typically the drugs are indicated for osteoporosis. There are some occasions where a patient with osteopenia, like for instance, if they're fracturing, would be recommended pharmaceuticals, but generally not. And so, what do we have for patients with osteopenia? Well, prior to Osteoboost, we would typically tell them get adequate nutrition, make sure you're getting your 1,200 milligrams of calcium, make sure you have enough vitamin D, do weight-bearing exercise. Well, they'll probably still lose bone, and they may not know what to do with this weight-bearing exercise recommendation, right? What does that really mean? And the physician is not a physical therapist. And most older women, even if they are exercising, they tend to do like walking and yoga and Pilates. They're not doing powerlifting. So the kind of exercise that you need to meaningfully impact your bone, is typically quite challenging. It's great for people to do that. And by the way, we always recommend that patients maximize all of the other modalities, but generally they will still lose bone or there's still an opportunity to improve their bone with something like Osteoboost.
So with Osteoboost, so what does the vibration do to help build the bone density?
Sure. So I mentioned that high impact exercise has been shown to improve bone density. Well, let's think about what high impact exercise does. It's providing mechanical forces to the bone. So your bone cells respond to force like shearing, kind of stress on the bones. And so think about if you jumped off of a 2-foot box, you would sort of send vibration waves up the skeleton. So we are essentially mimicking this natural exercise mechanism and applying it to the hips and lumbar spine. And so vibration for bone density has been studied for many years. So it's been studied at a cellular level. It's been studied in animals where you can do things like bone biopsies, right, to see how vibration is improving the bone density in like sheep and lambs. So that's been done. And then the next phase was to study it in humans. NASA funded studies on whole body vibration platforms for astronauts because astronauts lose basically a year's worth of bone in less than a month in space.
Wow.
So whole body vibration was studied there. And whole body vibration has been studied outside of this, astronaut NASA scenario. And, the data, as I mentioned, for whole body vibration seems to indicate that it should work. There are some studies where there are some results, particularly, as I mentioned, in the lower leg. But as you move up the skeleton, the data for hips and lumbar spine has been more mixed. But promising, and based on that promise, we just took this other application of vibration.
So, as someone who kind of fits the description of your patients, I'm 57, I have osteopenia. I went to my endocrinologist to see if I could take something like Evenity or something like that, but my FRAX score was not high enough to
Right.
qualify for medication. Can't take calcium because I have kidney stones. So there are a lot of reasons why women need options like Osteoboost. So if someone like me was like, okay, I want to look into this, it's a prescription based. So would they have to contact their doctor?
Um, so you need a doctor's prescription. And so there's a couple of pathways. You could just sit down with your doctor, tell them about it if they don't know. We are seeing that a lot of endocrinologists are prescribing. We were covered in, sorry, let me grab it, like this endocrine magazine. So a lot of the endocrinologists are very excited about this, and they're kind of one of the key specialists. But um, any doctor can prescribe it. We have a fax form on our website, which goes to our online pharmacy, or many of the excuse me, electronic medical records now show Osteoboost. So that is starting to get in place. And then the patient orders it from our website. So you can do it in either order. You can order Osteoboost, then take the form to your doctor, or start with the doctor. We also are going to be launching a telehealth option. So let's say it's hard to get in with your doctor or you don't have time. From our website, you'll be able to, and actually, I think by the time this airs, this should be live, you'll be able to link to, this telehealth option. And it's not even something where you have to get on the phone. You basically fill out a few screens and give your demographic information, your bone density information, risk factors, and then you can get the prescription sent directly to the pharmacy. And the cost for that should be, is pretty low. It's less than a typical copay. So, yeah, there are a couple of options.
And then
So
you get, I'm
you have to
sorry,
have your DEXA scan score
right.
ready before you do this.
Yes, yeah. And we really encourage that. We would love for patients to have a recent DEXA scan, of course, for prescribing, but also so that you can see how you're doing, right? Knowledge is power.
So true. So you get this in the mail. It looks like a belt. What
Mhm.
do women then do with it? Like, do you wear it low and then go for a walk? How long do you wear it? Things like that.
Yeah, so the vibration pack sits low on the back on the sacrum. It's a belt form factor that you wear around your hips. The treatment is 30 minutes a day. Most patients from the clinical trial have told us that it feels very good, that it tends to feel like a massage, it's quiet. So sometimes I'll use it when I'm like at my standing desk. The people on the other end of the phone, if I'm on a Zoom, can't hear it. But a lot of patients like to go for a walk, right? So you can't be sitting or lying down, you need to be upright, but you could be folding laundry or cooking or, you know, like I said, sort of doing chores or going for a walk. So 30 minutes is pretty easy to incorporate it. And you can use it while you're doing other things. So you don't have to set aside 30 minutes. You basically just have to remember to put it on. And, in the pivotal trial in Nebraska, we saw that patients used it very regularly. The average was about 4 times a week.
Does it go over clothing or under clothing or?
Over clothing, but it should be sort of reasonably normal to thin clothing. So you could wear it over slacks, over yoga pants, not over a down coat, because that would like dampen the vibration.
Yeah. And how much does it weigh when it's like on
Oh,
you?
it's just a few pounds.
Oh, good. Okay.
Yeah.
So it almost is like when you wear a weighted vest to go out to walk, you could.
Probably even less.
That's
Yeah.
what I'm saying. It's like you
Yeah.
can.
Yeah, well, yes. I mean, you could wear both, I suppose, but I think, yeah, it's similar in concept. Have you talked about weighted vests on the show?
Yes, we have before. Yeah,
Yeah.
we have.
Yeah, they're quite popular these days. It's really interesting. But there's not a ton of data on the bone side. I think there's a lot more data on general fitness, right? Because they do up your work rate. Um, but the on the bone side, the studies are small, but I'm hoping that there'll be more data coming out on them, right? Because we need obviously more options are good.
Right.
And the response for Osteoboost has been wonderful. I mean, you've been in Women of Wearables in the top 200. You were in Forbes recently. Did you expect to get this kind of response, or I know
I
you
have,
hoped, but did you?
yeah, it's a good question. Um, I'll say yes. I mean, specifically, I didn't know what would happen. But when I was recruited to the company in fall of 20, and I met with the CEO and the chief scientific officer, the CEO was looking to kind of replace himself with a full-time CEO. Um, I was like, if this works, because my background's in marketing, I knew what osteoporosis was. I saw my grandmother shrink. My dad was medical director of a nursing home, and I worked several summers in college at this nursing home. And I saw why people end up in nursing homes, right? Alzheimer's or hip fractures. I mean, I'm oversimplifying, but so I knew that, how important this was. And I had also been reading about the movement away from medications. People are afraid to use them, no early intervention. And so my thought was, if this thing works, this is a winner. I just, that's why I joined the company. We didn't have money, right? And but we had this opportunity. And my only question is, why will it work? And when I was interviewing with the company, my mother, who's a physician, she sent me a review of whole body vibration studies, and that review showed the data was very mixed, right? So she was a bit skeptical. But when I met with Mike Jasmer, our chief scientific officer, he's like, look, here's our hypothesis on why we think it didn't work, right? We need to apply the vibration locally. And I was like, okay, I think there's enough of an opportunity here that I'm going to dive in. And it took a couple of years for the trial to be done and analyze the data. And as soon as I saw the data was good, I knew we really had a big opportunity. Now, what did I not know? I had no in I didn't have my own intuitive sense about what the doctors would think. I knew that patients would want, or I believed that patients would want a non-drug solution, that patients would want an early intervention. But we're a small company, right? It's something sort of novel and different. Doctors are used to prescribing drugs. So what would the doctors think? And what we've seen in the last, 4 months is lots of doctors are really excited about this. We have, endocrinologists from literally, the top academic institutions, Stanford, UC San Diego, Columbia, prescribing this. I mean, these are doctors we haven't met with most of them. They read our study. They know that patients need additional interventions and they're prescribing. And so that's the part I didn't know about, and I'm so encouraged. And I'm really glad we went down this prescription path because that was a choice. We could have done sort of an over the counter, but we wanted to hold ourselves to the standard of evidence to be able to make medical claims and to partner with doctors. And from a business point of view, doctors, sure, it's a little bit of work for a patient to get a prescription, but doctors see all these patients with osteopenia, and they can really help us get to the patients who would benefit from this. So we're really excited about how that has been kind of evolving.
With insurances, what's the stance right now with insurance?
Yeah. So unfortunately, it is not the case that if you get FDA approval, you automatically get coverage. So we do not yet have insurance coverage. It is eligible for HSA and FSA. So for many people, that's helpful. But we are working very, very actively on gaining insurance. And so we're pursuing pathways with both Medicare and commercial payers. So we worked really hard on the FDA approval, and we're going to work just as hard on getting insurance coverage. And then, we've also tried to make it, some companies for medical devices, they price at such a level where there's no option for patients to self-pay, or it's just not realistic. So we know not everyone can access something that's, $995, but we did try to keep it within the realm of, it's maybe the same as a Botox treatment or, what you might spend on face cream, and yet you get this really, really important health benefit. So, and we're seeing pretty good response from patients on that.
Well, $995 is a lot cheaper than paying for a hip fracture.
Yes, hip replacement.
Yeah.
Exactly. Can you talk a little bit about the app that goes with it?
Yeah. So we have an iPhone app. We will be building also an Android app. And there's a couple versions. There's a basic version which tracks your compliance, gives you reminders, it integrates with Apple Health. You can track your calcium consumption and has educational modules. And then last July, we acquired a company called Wellen, Wellen. And Wellen, with the URL is getwellen.com, developed, and it was, kind of done with physical therapists and under supervision of doctors, an osteopenia and osteoporosis specific exercise program. And so we offer that as well. And that's sort of in our premium version. We've been including it for the first year for patients who pre-ordered. And that's a really great benefit for patients because, as I mentioned, they know they need to do weight-bearing exercise. Their doctors have given them that guidance. And then there's not a lot of specific direction of what to do, what exercises that are, most appropriate for bone health. Also, Wellen, which we renamed Osteoboost Fit, has a lot to improve your balance. So if you think about fracturing, typically it's from poor bone quality and falling. So it's also really important to, reduce risk of falls. And we think Wellen is really a great option for that.
We did work with Wellen, Bridgett, a couple years ago.
Yeah.
Oh,
Remember?
terrific.
Yes.
So Priya, who, developed that, is now our Chief Product Officer.
Oh, great. Okay. Well,
Yeah.
We love sharing with our listeners options that they can use, that they can take to their doctor and say, I want to try this. And if the doctor doesn't know about it, they can learn it and then share it with other people. So thank you for all you are doing. Sign me up as a postmenopausal woman with
Absolutely.
osteopenia. But again, knowledge is power, like you were talking about before. And we love hearing about options that are being created for women, whether it's perimenopause or postmenopause. So thank you so much for joining us and telling us about
You're
Osteoboost.
welcome. Thanks for all the great questions.